Okay, are there any questions about anything that we've covered so far in the class or anything that is coming up in the class? Do you have any questions about? I'm seeing a lot of no's. All right then. Let me move to our PowerPoint for this. We're still in therapy. That's what we're talking about. And we have discussed so far the insight therapies, and then I started to talk about the biomedical therapies as well. And I'm not sure, did I talk about nurse practitioners? Nurse practitioners are able to prescribe drugs as opposed to the psychologists. Psychologists cannot prescribe drugs. Psychiatrists can prescribe drugs, but so can nurse practitioners. If you have an option of going to be a nurse, and nurse practitioner is an option for you, it's a very good field. I was the patient of a doctor here in the town for 7 years and never saw the man. I only met with this doctor's nurse practitioners. He had 3 of them, 2 males and a female, and they did everything. I never met the doctor. The same thing is true in psychology for psychological evaluations and prescribing of drugs, and nurse practitioners, psychiatric nurse practitioners are a very interesting field. So there are many different types of mental health care professionals, and here's just a few of them. The counseling psychologist deals with the problems of normal living. The counseling psychologist doesn't deal with really hard issues. That would be clinical psychologists, psychiatrists would do that. The counseling psychologist deals with the worried well and normal issues. They work in schools, clinics, and other institutions, and they can have a master's degree and call themselves a counseling psychologist, or they can have a PhD or an EDD or a PsyD. PhD being a doctor of philosophy, EDD meaning a doctor of education, and a PsyD, a psychologist with a doctorate degree who is specialized in clinical work. The clinical psychologist deals with the same problems, the normal problems of living, but more severe. The more severe they are, the more you're going to go with a clinical psychologist instead of a counseling psychologist. So they work in private practice as well as mental health hospitals and agencies. And they will have a PhD or a PsyD. They will not have they have their master's, of course, but they've gone on and gotten their PhD or PsyD. In order to call yourself a clinical psychologist, you must have your doctorate degree. The psychiatrist has a medical degree because they are a medical doctor first. They have graduated from medical school, and then they have specialized in psychology. So they deal with the very severe mental disorders, often by means of drug therapies, and they will work in private practice, clinics, and hospitals, depending on how they perform their particular functions. And of course, they have a MD, medical doctorate degree. Some psychiatrists are psychoanalysts. Psychoanalysts are very specialized. They work with Freudian therapy. That's what psychoanalysis is, Freudian therapy. And they will work in private practice because insurance companies will not pay for 20 years worth of therapy, and it's going to take 20 years in psychoanalysis to get to where you want to go. So they have medical degrees because they are psychiatrists, but there are also PsyDs who can be trained in Freudian therapy and do psychoanalysis. You'd have to live in an area where there are very wealthy people and lots of wealthy people because they have to pay for their own therapy. So that is a problem with psychoanalysis. But it is the first type of therapy that was devised by Freud, and it still works today. So it is still a viable alternative to other types of therapy. As I said, the psychiatric nurse practitioner is a nursing specialty that's licensed to prescribe drugs and to work with the mentally ill. They work in private practice clinics and hospitals. They have an RN degree. Well, our college, you can take our college nursing classes and then take the certification test and become a registered nurse. And we have a 100% passing rate for our students taking that test. So you can become an RN just through your associate degree, and then you can go on and get a BSN, Bachelor of Nursing, Bachelor of Science, BS, Bachelor of Science in Nursing, and then you can get a Master of Science in Nursing, and you can get a PhD in nursing. And when you get a PhD in nursing, you're a doctor. Your PhD, you have to call people with a PhD Dr. So-and-so. So you may be a nurse, but they're going to call you doctor because you have your PhD. I think that's kind of funny. But they have specialized training in how to prescribe drugs. And so the psychologists can take those particular types of classes, and they can also become certified to prescribe drugs. The clinical social worker is a social worker. So they get a master's of social work, an MSW. They're social workers with a specialty in dealing with mental disorders, and they often are employed by the government. Not necessarily, but they can be, of course, because every single cities, counties, they all have social services agencies, and the social services agencies hire social workers. So the clinical social worker is specific to the clinical portion of it to help those people who need therapy in some way, shape, or form. One of my friends in college at the University of Georgia got her MSW at the same time I was getting my Master of Science in Psychology. And she got hired almost immediately by a hospital in Atlanta, and she stayed in that hospital in Atlanta her entire career. She just loved it. It was an absolute joy to her to work that way. So if this is something that you're interested in but not interested in psychology, maybe social work will be interesting to you. And then we come to the pastoral counselor. And I have a problem with pastoral counselors, not the fact that they are pastoral counselors. I think that's wonderful. We have a university right here in our city, the Mid-Atlantic Christian University, MACU, and it produces pastoral counselors that are very well trained. The problem with pastoral counselors is because we have a separation of church and state in this country, you can say, I'm declared by God to be a pastor, and you can go out and you can start your own church, never have any training whatsoever, and do more damage than help those people that are your flock. And so the pastoral counselor combines spiritual guidance with practical counseling. They work in religious orders and ministries, and their credentials vary from zero, nothing, to a full PhD and all the counseling that they need. So I have a problem with them because there are people like Jim Jones. And if you don't know Jim Jones, he declared himself a minister, gathered a whole lot of people around him, took them all down to an island in Central America, and killed every single one of them with Kool-Aid laced with arsenic. Have you ever heard the saying, don't drink the Kool-Aid? Nobody ever had that saying until Jim Jones. And now we have the saying in our vernacular, don't drink the Kool-Aid, because what they're basically saying is that person is lying to you. Don't buy it. Do not buy it. And keep away from them. They're dangerous. Don't drink the Kool-Aid. There are people, besides those that I just talked about, there are people who graduated from high school and never had any other training except very specific training in, let's say, substance abuse counseling. They were substance abusers themselves, maybe, and they went through substance abuse counseling, came out the other side in a positive way, and then got training to be a substance abuse counselor. And according to correlational data, they are just as effective at being substance abuse counselors as a person who is a highly trained PhD professional using insight therapy. Now, we'll talk more about insight therapies and behavioral modification, but just because they're good at insight therapy does not mean that they're good at behavioral therapies. So they are good at insight therapies. And these people may only have a high school diploma, but they could get a job, not in North Carolina, because in North Carolina, by law, you have to have a master's degree in social work or in psychology in order to be hired by the mental health centers in the state. But in other states, they can be hired, and they are they are very capable of doing insight therapies and helping the substance abusers to find a way to get out of their substance abuse. So as an insight therapist, they're very good, but we're not saying that they're great at all different types of therapy. We'll talk more about the therapies in a minute. In the United States and in other industrialized, individualistic countries, we have people that are more tuned to one-on-one individual approaches to therapy. So that's traditional Western individualistic therapy is one-on-one therapy. However, we do have group therapies, not large, giant groups, but smaller groups. More individualistic approach through group therapy is an option. And then there's the network therapy of the collectivist cultures. We've talked about these as well in other lectures. In collectivist cultures, the entire family, friends, co-workers, and anyone else that's associated with the client are drafted into the process of helping the client improve. It is not one-on-one. It's not one-on-one. It's everyone in society that has anything to do with this one person who has an issue, helping them to get through, because society is important and every single person has their place in society. And if somebody's out of place, society may not function successfully. And so we need everybody to be there, and that means everybody is a part of the process of helping someone in network therapy. And then we have mystical therapy. And I'm not talking about the type of therapy that the Spanish Inquisition used. If you weren't the right religion, well, then we'll just burn you at the stake or torture you to get the demon possession out of you until you confess your sins. And that's not what I'm talking about. So this is a collectivist ancestral approach, and rabbis and mullahs and priests and shamans will perform this particular type of therapy. And even exorcism is a possibility. That exorcism doesn't exist as much as it used to, but there are still exorcists in the Catholic Church. So I'm going to pick shamans here. Does anybody know what a shaman is? Has anybody heard the name shaman before? So some of you have heard the word shaman before. I'm going to be talking about the shaman who is the American Indian medicine man. That's the shaman I'm going to talk about, the American Indian medicine man. The American Indian medicine man had hundreds of years. They were passed down through families from son to father to son to father to son. You just keep on going. And sometimes to the girl in the family, if there was only a girl in the family as well. And they had hundreds of years worth of data that they had collected. And what happens is, let's take today's American Indian, you're sick, you go to the medicine man's house, the medicine man puts you in a room, the medicine man dresses up in a specific costume, dances a specific dance, chants specific chants, burns incense, and gives you herbs. And the question, of course, I always ask is, would that do anything? Is that going to help a person to get better? What do you think? Yes or no? Will it help a person to get better to do all that? And Lauren says no. Anybody else? Another no from Anna. Some more no's, right? And that's my typical answer that I get from my students, no. But remember what placebo effect is? If you think something's going to work, then 33% of the people will get better, because as the man's dancing around, as the medicine man is burning the incense and chanting the chants, you feel better because you think it's going to get better. Your stress level decreases. When your stress level decreases, your immune system comes back online and you get better. But that's about a 33% is what we see maximum. 33% will get better in that case. But shamans have a much, much higher rate of success than 33%, surprisingly. So why would a shaman have such great success at getting people better? The answer to that is herbs. Every drug we have today traces its ancestry back to some herb somewhere. And these medicine men have hundreds of years of knowledge of what herbs go to do what kind of thing, and it's passed down from generation to generation to generation, and we lost a great deal of information when we killed off the Indians and the medicine men. Some of the shamans still exist today and have some of the information that they have gotten from their ancestors, but not as much as we had back in the day. So herbs. Let me take one herb, for instance, since we're talking about psychology in this class. I'll take St. John's wort and talk about St. John's wort. St. John's wort you can find in any store, anywhere that sells drugs. You can find St. John's wort in the herb section. Walmart, Kmart, and Walgreens, the drugstore, CVS, the drugstore, you can find St. John's wort. What does St. John's wort do? If you are extremely anxious and take St. John's wort, it mellows you out. If you are extremely depressed and you take St. John's wort, it brings you back up to normal. St. John wort mellows you out to be a normal disposition. So should you take it? And I'm going to say no. And there's a reason why I'm saying no, because you don't have all the information you need. Yes, it does this. But if you go cold turkey off of St. John's wort, you go, I feel better now. I don't need St. John's wort anymore. And you were a person who was anxious. Now you're middle of the road, feel pretty good, get off St. John's wort, boom, you're going to shoot through the ceiling in anxiety. If you're in depression and you were in depression, you came back up, and you take St. John wort, you're going to fall like a brick into suicidal tendencies. You cannot go cold turkey off of the St. John's wort. You have to go very slowly off of St. John's wort, and you should be seen by a medical person. The medical person needs to know that you are on St. John's wort because they might want to prescribe you some kind of drug for something else, and St. John's wort could interfere with the efficacy of that particular drug. And drug companies don't test their drugs against herbs. I mean, St. John's, you can go out to your yard and probably find St. John's wort. You don't have to buy it. You can probably find it out there. But they don't test it against that. They only test it against other drugs to know what the efficacy is against another drug and see if they compete with each other. So I'm not saying don't take St. John's wort, but I am saying you have to know how it works. And of course, medicine men knew exactly how it worked. They had hundreds and hundreds of years of studying that particular herb and all the other herbs that they used. And that's why mystical therapy does have some truth behind it, because it's not just mystical. It's got placebo effect, of course, but it also has a lot of other knowledge that comes behind it as well. Many, many years of knowledge. So what kinds of treatment exist for mental disorders? We've already discussed the different types. Two main types that psychologists use are psychotherapy, which can be behavioral therapies, and insight therapies. So let's talk about the behavioral therapies first, and then the insight therapies in more depth. So first, behavior modification. Of course, we all know because we've gone through the learning section. Hopefully you remember it. So modifying behavior through specific approaches derived from classical and operant conditioning experiments. And so we're talking about reflex actions, that's the classical, and operant is rewards and punishments. So counter conditioning is a set of classical conditioning techniques that substitutes a new response for an unwanted response. We talked about this in the learning chapter. Used a great deal when the client has an anxiety disorder such as a phobia. I know I don't like snakes. I'm fine that I can hold them, but spiders, I don't want to do anything with spiders except kill them or get away from them. But I have held a tarantula in my hand before and not freaked out because it's a fear, not a phobia. So I still have, my mental faculties are still in control. I still have logic, and my emotions have not trumped my thoughts. That's phobia. When emotions trump your thoughts, that's a phobia. So two forms of counter conditioning: reciprocal inhibition, which is counter conditioning involving reflex reactions, and this is relaxation training. We tense up really well. Every single one of us tenses up really easily, but it's very difficult for us to relax. So we have to learn to relax. Really, if somebody has an issue and it is related to being tense, we need to teach them to relax, and we need to connect it to some sort of a sound or smell or something so that we can recreate that relaxation at the sound or smell. And this is usually paired with systematic desensitization. This is a technique in which anxiety is extinguished by exposing the patient to an anxiety-provoking stimulus in gradual steps, while they are relaxed. The client must develop an anxiety hierarchy, then practice relaxation, and finally learn to associate relaxation with the anxiety-provoking stimulus. So let's say you're afraid of snakes, because so many people are. And what is your lowest level of anxiety about a snake? And maybe it is picture of a snake. A picture of a snake may produce some level of anxiety, but a small level of anxiety. And then being in a building maybe where you know that there's a snake in a locked room somewhere, and that snake is not only in a locked room but in a locked cage as well. But that produces a little bit of anxiety, maybe higher than what the picture does. And then being outside the room that's locked with the snake on the other side, then maybe an unlocked door, still closed, but not locked anymore. Why? Because you don't want the snake to get out and unlock the door. It's not going to happen. So, but maybe that's a next level of anxiety. Having the door open and actually seeing the snake on the other side of the room that's in its cage, that's locked up, coming into the room with the door closed behind you, that inside a room where there's a locked snake, and being closer and closer to that particular locked snake, right, in its cage, until finally the highest level of anxiety is holding the snake. That's the highest level of anxiety. So we have a hierarchy. Now what we do is we start from the base, and we chop out the base and chop out the base and chop out the base. So we show you a picture of a snake, and it makes you tense. We relax you, click, 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 because we just taught you to relax to the clicker. So now you're relaxed, you're looking at the snake. We take the snake picture away, we give you the snake picture back again, you tense up again, and we do this until you do not tense at the picture of the snake. So we have chopped out that bottom hierarchy. Now the next hierarchy, what is the next one? Being in a building with a room somewhere in the building that has a snake in it and it's locked up. Now we get you in that, we give you that particular environment, and then we relax you until you can be in that building and relaxed, knowing that there's a snake in the room and in the building, and then slowly going up the hierarchy until we've destroyed all the tension that exists all the way up to the point where we can have you holding a snake. And this does not happen overnight. This takes a long time to develop, to remove all of this tension in you and to develop this lack of fear of a snake. But we can do it through systematic desensitization. I said there are two forms of counter conditioning. The second form is called extreme desensitization or exposure therapy, or as I like to call it, the Indiana Jones method of getting somebody to be unafraid of a particular item or animal. So remember in Indiana Jones, if you saw the movie, he was afraid of snakes, and then he was thrown into a pit of snakes. And if he came out of it, he doesn't fear snakes anymore. But this is also very dangerous. If you have a heart condition, you don't want to put somebody through that kind of fear because they could have a heart attack. So yes, exposure therapy works under specific conditions, and obviously being seen by a medical person. You yourself do not want to push somebody into a pit of vipers. So it's a type of desensitization therapy in which the patient directly confronts the anxiety-provoking stimulus as opposed to just imagining it. And we have a saying in the United States, get back up on the horse. And this is pretty much the idea of exposure therapy. I loved horses when I was a kid, and my mom got me horse riding lessons. And I've been thrown by a horse and dragged by a horse and stepped on by a horse and nipped by a horse and bucked by a horse, actually knocked over by a horse. They're wonderful, wonderful animals, but it's a 2,000-pound animal, and if they move the wrong way and you happen to be in their way, bang, you're flying against the wall. So they win that headbutting, they win it, okay? So get back up on the horse. Whenever anything bad happened to me, my mom would not grab me, run away from the horse and go, oh, you poor thing, that horse, it hurt you. I would have developed certainly an anxiety, a phobia about horses. No, she picked me up, put me back on the horse when I was thrown by the horse or dragged, whatever happened, picked me up, put me on the horse, and had me petting the horse's neck and saying, it's okay, I didn't mean to hurt you, horse. And I know you didn't mean it, horse. And so I got back up on the horse. I had exposure therapy that kept me from getting the phobia of a horse. My mom was she was an amazing woman. She still is. And so virtual reality also works. Virtual reality, when I started teaching, there was no such thing. There was no such thing as virtual reality 16 years ago. Today, you can put on these little goggles and you can look around and see as if you're inside of a room filled with snakes. Exposure therapy without any snakes being used, right? You can get these goggles. Have any of you actually used goggles yet? Are they that well found all over the place? Does anybody use virtual reality to play anything or to view anything yet? Any of you? Seeing lots of no's. So interesting. It's still not. Yes, they are very, yes, you are correct, Lauren. They're expensive. At this point anyway, they're still pretty expensive. Although the Google ones are not supposed to be as expensive as others. But yeah, they're interesting little devices. I still don't have them. I'm still trying to get enough money together to buy these glasses that help with color, people with color vision. They're $300 a glass per glasses. But I want to own some for my students so that when we are together again, and I have a student that has color vision problems, I can give them these glasses to look through so that they can see if they actually work for them or not before they go out to buy $300 glasses. And I'd like to have some of those at school for my students to use. But so virtual reality exposure works just as well to get rid of the phobias as true exposure therapy does. Another counter-conditioning technique, of course, is aversion therapy. We've already talked about this one too. It involves presenting individuals with some attractive stimulus, the thing they want to get rid of that they're happy with, like cigarettes. So they want to get rid of smoking, but it's a very attractive stimulant to them. They are addicted to the nicotine. They're addicted to the psychological holding that thing in their hands. They need that thing in their hands. So we need to find a way to get rid of that, and I've already talked about this in the lecture on learning. Well, you connect it with an unpleasant stimulus. You lace the cigarettes that they have with a chemical so that when they light it up, it produces the most god-awful smell and taste so that they want to throw up, and then they relate the reflexive throwing up reaction to the cigarette, and they don't want the cigarettes anymore. Now, of course, they have to want to quit because they just throw those out and they could get some cigarettes that weren't laced, and then that doesn't work very well. So that is aversion therapy. We can use the principles of classical conditioning to get rid of some behavior that they do that they don't want to get rid of, that they want to get rid of but they can't get rid of, by pairing it to a reflexive action that's just disgusting. Then we can get to the operant conditioning, where we take care of the rewards and punishments. So approach to change behavior by altering the consequences, especially the rewards and punishments of behavior. Some behaviors are simply rewarded and they're bad behaviors, but they've been rewarded and therefore they are the behavior that this person has. We do this to children all the time. When they're bad, we pay attention to them. When they're good, we go, oh, they're being good. They're being good. Let's just, be quiet. Don't interfere. Let them be good. No. When they're good, grab them, hug them, tell them how great they are. Pay attention to them when they're good. Don't just pay attention to them when they're bad. And that's one of the reasons why they're bad. They get their attention when they're bad, and that's what they want. They want the attention. So, hey, bad behavior gets attention. I know it might not be the best kind of attention, but at least I'm getting attention. So give them attention when they're good. Don't give them attention when they're bad. Try their best to sort of ignore the bad behavior, and the bad behavior will slowly disappear and the good behavior will increase. Social learning therapy is based on social learning theory, which teaches that behavior is influenced by observation and imitation, or as we have a saying in the United States, monkey see, monkey do. You can watch monkeys. One monkey does something and it gets positive results. All the other monkeys are going to do the same thing. So monkey see, monkey do. And I've actually had a case of this where I saw this happen. This is called participant modeling, where the therapist will model the behavior that you want the client to do, but the client doesn't get it. So there was a woman I knew, she was Asperger's, and we were at a party once, and the guy came up to her and said, "Hi, I'm George," and held out his hand, and she said, "Hi," and she turned around and walked away. It's like, wait, go and grab her. "What are you doing? He wanted to meet you. He wanted to talk to you. He was interested in you." Really? So what you need to do is to model the behavior. Hold out your hand. Say, "Hi, my name is Roger. What is your name?" Or just, "Hi, my name is Roger. Hold out my hand." What are you supposed to do? You're supposed to grab my hand and shake it and say, "Hi, my name is Mary." That's not her name. I'm using a different name. "Hi, my name is Mary." All right? So you show the person and teach the person how to behave. And of course, it works really good with Asperger's because they need that connecting. They need to know what to do, when to do it, because they have a hard time making the connection between what other people do and what they're supposed to do. So the therapist demonstrates and encourages a client to imitate and desired behavior. It's a lot of times it doesn't have to be the therapist. It can be someone that they admire, their father, their mother, some sports figure. If you have access to that sports figure that they like, then the sports figure can model the behavior as well. Token economies are taking a particular reward that is not by itself useful but can be traded in for something else. That's what a token is. So you can apply it to groups like classrooms and in mental hospitals as well. In mental hospitals, in the ward, in the main ward, usually there's one television. That television is behind bars, and the patients cannot touch it. The nurses decide what goes on the television. Well, if you've developed enough, if you've accumulated enough tokens, you may get a day where you get to decide what goes on the television. And that's very powerful for mental health hospitals. So involving distribution of tokens contingent on desired behavior, and then those tokens can later be exchanged for privileges, food, and other reinforcements. So that is the behavioral therapies, and now we talk about the insight therapies. Freudian analysis, of course, is the #1 well-known psychoanalysis therapy. And in psychoanalysis, according to Freud, there are 3 important things to consider: the unconscious motivations, what happens to us, why we are doing this, that we don't even know why we're doing it. Conscious motivation is not a problem. It's the unconscious motivations that are the problem. And early childhood development, of course, before the age of 21. And then the dynamics of the client's personality, usually not very powerful portion of the problem. The other psychoanalysts, the newer psychoanalysts and post-Freudians, they look at the person's current situation more. Analysis of transference is a term that you should know, and it shows that psychoanalysis is coming to an end. We have finally gotten to a point where we're finalizing psychoanalysis. So psychoanalysis, I said, it can take 20 years to go through. By the time you're through with it, it's very possible your parents are no longer alive, but according to Freud, it's very possible the problems exist because of your parents. So how can you deal with it? Well, in analysis of transference, what happens is that you start to react to your therapist as if they were your mother or your father. So in this final stage of psychoanalysis, the therapist takes on the attributes of the client's parents, and then the client, the patient, can then deal with the issues through their therapist instead of having to deal with it directly with their parents, the mother or father. And when this happens, you know that psychoanalysis is coming to an end. The newer ones, Jung, Adler, Horney, and Erickson, they were all also Freudian analysts, but they looked at the individual's current environment. If they're 50 years old, what's happening to them right now? Not looking at 21 to 50 and going, nothing matters between that time frame. No, what is happening right now? Influences of life experiences beyond childhood, social and interpersonal relationships at the time of the break, and conscious self-concept of the individual as well. The humanistic therapies, the therapist is looking to help you to become self-actualized through the pyramid of Abraham Maslow, the hierarchy of needs. And some of the terms that they will use is things like reflection of feeling. So I might come into my therapist's session and sit down and go, I'm feeling pretty good today. And the therapist would say, I hear you saying you don't feel very good today. Because it's not the words, it's the body position, it's the facial expressions, it's the tone of voice are much more important than just the words that are given. So reflection of feeling is paraphrasing the client's words to capture the emotional tone that's being expressed. The unconditional positive regard we've talked about as well. We talked about Carl Rogers, and the therapist's attitude of non-judgmental acceptance and respect for the client. Not what the client has done, not what the client thinks, not the issues the client has, but the client themselves are a wonderful creation of God, and there's something in there that we need to repair, and yet we need to find that person that's in there, the unconditional positive regard for the person that is inside, the soul that's inside. So that's unconditional positive regard. And Carl Rogers said it's not easy. He said he's sat across from people who did atrocities in war and trying to look at the person, knowing what they had done, trying to have an unconditional positive regard for that person, not for what they've done, and try to work through the issues that they have. It's not easy, but it should be done. And then non-directive, I told you that therapy can be $150 an hour, down to zero. If your taxes show that you haven't made any money, you can bring in your taxes and they'll, in the state of North Carolina, drop it all the way down to zero. But if you're at $150, let's say you're at $150 an hour, and you come in and you sit down in your chair and just lean back and you don't say anything, nothing at all. You're just sitting there. The therapist is going to sit there too and never say anything. You, as the client, have to start the conversation, and this is why. If the therapist says anything to you, it will set up a thought process in order to register what they said and to respond to what they said, and it will change the way that you're looking at your world at the moment, and it's what you have in your brain at the moment without anything external influencing it that is important. So you have to come in as the client, sit down, and say something to get the conversation going. That's called non-directive, meaning the client takes the lead, the therapist does not take the lead. Does that make sense to you guys? Do you hear that? Okay, I'm seeing a lot of yeses. All right. Of course, in individualistic therapy, doesn't work all the time because you have to have the other person there sometimes, couples counseling, marriage counseling, family counseling. So We do have group therapies in the United States, psychotherapy with more than one client. One of the special ones we have in group therapy is self-help groups. Groups of people that have the same issue. So this is group therapy, and it's usually run by laypersons, paraprofessionals, people who have gone through the therapy, come out the other end successfully, and have been trained to run a group, and so they will run these groups themselves. So they're organized and run by laypersons, people who are not professional therapists, and there are 15 million people attending self-help groups in the United States every year. They are for marital counseling, as I said. Marriage is not the beautiful, great, incredible thing that Hollywood likes to make it out to be. People are people, and when you have two people living together, there's going to be conflict. But when you communicate properly, then you work through the conflict, and if you can't communicate properly, well, marital therapy will help to get that communication going. Couples counseling, 100%. Every couple that wants to get married should go through couples counseling or premarital counseling. Then there's family therapy. Family therapy is you, your spouse, the children, and animals as well sometimes, because many times you've got a dog that's lived with you in your house for 2-3 years, and then a little child comes along, and all of a sudden the dog is not number one anymore, they're number two, and that can cause some issues, and the way that you start to behave toward that animal produces even worse issues. And so family therapy can actually include animals as well. And AA, everybody knows Alcoholics Anonymous. But right here in Elizabeth City, we have an NA group, N Narcotics Anonymous group, right here in Elizabeth City. So there are all kinds of self-help groups. Cognitive behavioral therapy is a combination of both the cognitive therapy we just talked about and the behavioral therapy, because a lot of times your behaviors are habits that you've developed, and those habits have been developed because of your thought processes, but you have to get rid of the habits as well as the thought processes, so you need a combination of cognitive behavioral therapy. Since thought processes drive your behavior, you probably have habits that are related to the process, the pattern of thoughts that you have developed over your lifetime, so the combination of both cognitive and behavioral therapies could be the best strategy for you. And I particularly like this. I've trained behaviorists. That's my specialty, is behavior, and as an animal psychologist. And the cognitive portion of it, I think combining the two is the best approach. That's my opinion. There's no research to show that one type of therapy is better than another type of therapy. So CBT, which is cognitive behavioral therapy, CBT is defined by Aaron Beck, and Albert Ellis defined rational emotive behavioral therapy. The rational emotive portion is the cognitive part of BT, behavioral therapy. So rational emotive behavioral therapy. And he is considered the grandfather of the cognitive style of therapy, while Aaron Beck is considered the father of cognitive therapy. So CBT combines cognitive emphasis on thoughts with behavioral strategies that alter your reinforcement contingencies. And this approach also assumes that irrational self-statements are the cause of our maladaptive behaviors. Irrational self-statements. Remember, the humanists believe that we're very rational creatures. We're not. We're very irrational creatures, and we think very poorly in many cases because emotions trump thought, and many times when we're making these irrational statements, we're in an emotional state and we can't think properly. So these irrational self-statements cause some of our maladaptive behaviors. And this strategy attempts to increase your self-efficacy, and that means self-efficacy means your self-worth, your self-value, and your self-effectiveness. So in cognitive therapy is a type of therapy emphasizing rational thinking as the key to treating mental disorders. And Aaron Beck believes that depression occurs because of negative self-talk. We don't wake up in the morning, look at ourselves in the mirror and go, hey, gorgeous. We look at ourselves and we think horrible things. We overgeneralize often. We don't talk about, not only do we not talk about ourselves well, because every time we do something bad, we go, oh, we're so stupid, we're such an idiot, we're so ignorant, we're just negative things about ourselves. But when we do something good, we don't talk about how good we are. So because we're taught to hold down our egos, depress your egos, keep your ego in check, right? Well, yeah, for a narcissist, that's probably a good idea. They need to do that. But most of us are not doing enough to promote ourselves to ourselves. There's enough people talking bad about about us behind our backs. We should be talking good to ourselves. We also overgeneralize the problems, and we minimize the positives and maximize the negatives. So one of the greatest positive self-talk advocates is a man named Shad Helmstetter, and you can find a lot of his books online. I use alibris.com. That's my favorite place for used books. And one of his books is What to Say When You're Talking to Yourself. They're little scripts that you memorize so that when you wake up in the morning, you say something good about yourself. And it's not, excessive, great, wonderful, lavish things about yourself. They're useful information that people should be saying to themselves, and in the afternoon, in the evening, before you go to bed. So these are positive verses that you need to be talking to yourself positively, because we just don't. We don't talk about ourselves positively. So the cognitive therapy will emphasize evaluating the evidence of the statements. So I'm so stupid. Okay, what is the proof that you're so stupid? Well, this happened, and so I'm stupid. No. Attribute the blame to situational factors. No, anybody that had found themselves in that situation would have happened. Even Elon Musk or Bill Gates, or find the really brilliant people in the world. Einstein would have happened. This would have happened to Einstein too in the same situation. You are not stupid. That is not proof that you're stupid just because this happened. Right? And alternate solutions are discussed about how to look at this particular situation, this environmental factor that happened. So evidence shows that cognitive therapy is just as effective as medication in relieving depression. So people who are depressed can take medication, or they can have cognitive therapy, and the cognitive therapy works just as well as the drugs. But drugs have side effects, and cognitive therapy doesn't. So you're better off with the cognitive therapy, but cognitive therapy takes time, and drugs are like, give it to me, give it to me. Right? So we'll discuss the drugs issue in a little while in this particular session. But this is sort of like the idea of teaching a man to fish. This goes back to an ancient Chinese proverb. You give a man a fish, you feed him for a day, you teach him how to fish, and he can feed himself for the rest of his life. And so with cognitive therapy, you are teaching somebody how to deal with their issue. If you give them drugs, you're just giving them something to take care of the problem, which they're going to have to come back to every single month or every 3 months to get their new drugs, and they don't know how to deal with it themselves. And that's what therapy does. It teaches you how to deal with it yourself. Now we come to the rational emotive behavioral therapy, and this is hard therapy. And remember, I said you have to find a therapist that you're comfortable with and that you relate to, but also a therapy, a type of therapy that you can get through. And some people cannot get through rational emotive therapy. It's very in your face. I've seen some of the videos, recordings of people doing rational emotive behavioral therapy, and I could not believe that the client didn't punch the therapist in the face at some of the stuff they were doing. So rational emotive behavioral therapy is a cognitive behavioral style that was developed by Albert Ellis. Irrational thoughts and behaviors are the cause of mental disorders. So this therapy tries to eliminate the ineffective, self-defeating thoughts. Some people are on a primrose path to nowhere. Worse, some people are on a primrose path to hell. It looks really pretty, but they're headed for the wrong destination, and you've got to figure out how to tell them that what they're seeing is not reality. And in rational emotive therapy, it is in-your-face type of therapy. So an example, client says, it's not fair. Did somebody tell you that there's such a thing as fair? They lied to you. There's no such thing as fair. There's just the earth. The earth exists, we exist, and what happens, happens. There's no fairness or unfairness about it. Stop talking about fairness. It just happens, right? And who said it was supposed to be fair? the therapist will tell that person. Or, she hates me. There are 9 billion people on this planet. I'm sure I can find somebody else who will hate you. That has nothing to do with it. Who cares about them? Why are you caring about someone who hates you? There are 9 billion people on the planet. Most of the people don't know you at all. Then there's the people who like you. Concentrate on the people that like you. Stop concentrating on the people that hate you. Drop them out of your life. You don't need them. So why does 9 billion people have to love you? Does everybody have to love you? No, just this one person. Why does that one person have to love you? Find somebody else. And this one, I know somebody like this. Why did this happen to me? Oh, me, poor me. Oh. I have a person I know who was in a car accident 20 years ago, and their leg was crushed. And the doctor said, you're never going to walk again. They're walking today. They are walking today, but they're walking with a limp. And they complain every day about walking with a limp. Come on, get over it. You have an anchor holding you back here. Cut the rope, the anchor. You're not going anywhere forward with that rope you're dragging behind you. Right? Get rid of it. Stop complaining. Stop evaluating your world and just get on with your life. And this is a very, very intense type of therapy. And how many of you would be able to put up with that kind of therapy? Anybody? Yes or no? Could you put up with this therapy? Nope, no, nope, no. Right. My mother, I talk about my mother a lot. She's still alive, amazing woman. She was a vice principal of elementary school. She was a teacher for a long time, and she was the second woman ever to be appointed to a magistrate's position in the state of Virginia. So she was only the second female magistrate in the state of Virginia. And she has some really cool stories. If you've ever seen the old show called Night Court, that was basically her. She's in Virginia, and she's in Northern Virginia. Northern Virginia shares space with Washington, D.C., and she says she would talk about people coming in that she would put into jail for the night for being drunk, and they'd be like, do you know who I am? She said, yes, but you don't know who I am, and that's why you're going to jail. And we call those people congressmen and senators today. But besides that, she had this one guy who kept coming in, and she would sit him down. She'd talk to him about what he'd done and why this was not the right thing to do. And she's very calm, stoic individual, very level. And she would talk to this person and try to get him to change his ways. And every month or so, he'd be coming back in. And his level of problems kept escalating, so that she was sending him to jail. But eventually, he's going to go to prison if he doesn't stop this. And one day, he came in, and she just had enough. And she just went off on this guy. And now she's not like that, so all the police officers in the building come running into her room. Are you okay? What's the matter? And she's like, get out, close the door. And she was laid into this guy, laid into him like rational emotive behavioral therapy would. But where you, as the client, can get up and move and leave if you don't like it, he's stuck in that chair, and she's just laying into him about what he's doing and where he's going. Primrose path to hell. And then it was way later. She was walking down the street in Washington, D.C., and a guy came up to her in a three-piece suit with a tie and said, you know, do you remember me? And she's like, you're familiar. And and it was this guy. And he said, no one had ever talked to me like that before, ever. And now he had a job. He was holding down a job. He had set himself straight, or she had set him straight. But that's rational emotive behavioral therapy. She did that on him. And it worked for him. And like I said, you got to find the therapist that you can relate to and the therapy that you can get through. And he didn't have any choice. He just had to sit there and take it. But you, as the client, can get up and just leave if you don't like it, and then find some other way to do it. So you need to find the therapy that you can get through. When we evaluate therapies, we can't do this scientifically with experimentation. We do it scientifically through correlation, because we can't purposely make a person anxious and then put them into therapy to see if it works, and then put them in a different therapy to see if that works. And so we're not manipulating variables, therefore we can't call it an experiment. So it's not really an experiment that we do to do this, but we need to ask the questions. Does therapy make a difference? Would people get better without therapy? Is therapy simply a placebo effect? Would the patients get better if she did not believe that the therapy would work? And we've asked these questions. We've looked at people who have gone through therapy, correlational experiments, not experiments where we manipulate variables, but we talk to millions of people who have had an issue, gone to therapy, and we find out whether it helped them or not. And then we find also millions of people who had issues that did not go to therapy, and look to see if there's a correlation there with people who get better without therapy. And there are definitely. Does therapy make a difference? Yes, it does. Would people get better without therapy? Yes, they do get better without therapy. And here's where the therapy makes the difference. When they have a relapse, they are in just as bad shape when they got better without therapy. If they had therapy, they have a means to look at their issue. They've learned what to do to look at their issue, to figure out how to apply the ideas of therapy to it for themselves, self-help at this point. And they also they can go back to the therapist if they need to. But is therapy simply a placebo effect? No, it works way better than just the placebo effect does. And would the patient get better if she did not believe the therapy would work? Well, we know from correlational studies that people who believe the therapy will work, it ends up being better for them than those that did not think that it would work. They still get better, but it takes a lot longer for them, and it doesn't hold as easily. Different insight therapies are roughly equivalent in effectiveness. Doesn't matter what kind of insight therapy you have, and it doesn't matter who the therapist is. It can be a PhD, a master's degree, or just a paraprofessional. As long as it's insight therapy, it will work just as good as any other insight therapy does. The quality of the relationship between the therapist and the client is the key. We find in all these correlational studies, if the client and the therapist get along well together, then there's going to be success, much greater success than when they don't get along together. And there have been some studies, there have been people trying to say, well, if you have this kind of if you have this kind of issue, this therapy would be the best. So specific therapies have been suggested for specific conditions, but as I said, the experiment showed that any type of insight therapy is just as effective as any other type. There is nothing yet that says if you have this issue, you should have this therapy, and then you need to find the therapist that does this therapy that you can deal with, that you have a relationship with. We don't have that connection yet. Then we can come to the biomedical approaches, talking about drugs, surgery, and electroconvulsive and magnetic stimulation. But before I do, are there any questions? Does anybody have any questions about this yet? No questions yet. Okay. All right. So let's talk first about drugs. Drug therapy. Antipsychotic drugs are those that are used for those with psychosis to help to relieve some of the problems of the hallucinations that they have in hearing as well as sight. And these are thorazine, haldol, chlorpromazine, haloperidol, and clozapine. And they do all of these work to relieve symptoms. They won't fix the psychosis like schizophrenia. They won't fix schizophrenia, but at least they reduce some of the psychotic symptoms. But if you take them long enough, they cause issues. So what they do is they remove dopamine from the system effectively either by lowering the amount of dopamine that's released, that's one type of drug, stopping the dopamine from affecting the other side of the neuron, so they're released into the cleft, but there's something blocking them so they can't get to the other side, so a blocking mechanism, or they could be used to cause the dopamine to be metabolized faster so it doesn't have as much time to react to the other side. So there are lots of ways that drugs can help to relieve the psychotic symptoms. They have some major side effects, and one of the major side effects is tardive dyskinesia. And tardive dyskinesia is an incurable disorder of motor control resulting from long-term use of these psychotic drugs. How tardive dyskinesia works is if you're taking Thorazine for a long period of time, you may get tardive dyskinesia. But if you take Thoradine for a period of time, then switch it to clozapine, then switch it back to haloperidol, and then back to Thorazine again, then you won't get tardive dyskinesia. It's staying on the same drug for too long that causes tardive dyskinesia. And in tardive dyskinesia, you would lose your ability to control the edges of your mouth, so you'd be drooling all the time. You'd be moving all the time, because like Parkinson's disease, you've lost the ability to control your motor muscles. And of course, you'll have to wear diapers because you'll have lost control of your sphincter muscles as well. So it's an incurable disease of motor control, resulting from long-term use of these antipsychotic drugs. And there's one group of people who have a much higher percentage of tardive dyskinesia than the normal population. And those people are called psychiatrists who self-medicate. You're not supposed to self-medicate. You're not supposed to write your own prescriptions. You should have a doctor watching you so that they know and they see what changes are happening in you, because we don't notice small little changes, and we get used to those small little changes so that the next small little change doesn't seem like a big change. It's just a small little change based on where my new normal is. So you have to have somebody that's watching you all the time, and some psychiatrists do not. And I worked with a psychiatrist who was just the most fabulous psychiatrist. She was just wonderful. And she developed tardive dyskinesia because she was self-medicating, and she no longer practices because you can't be with a psychiatrist who's continuously moving, unable to control themselves or write anymore, who's drooling and who smells like they need to go to the bathroom, or they just did. So it's a horrible disease. There's no cure for it, no matter what the drug companies try to tell you about on television. They can relieve some of the symptoms slightly, but it is an incurable disorder of motor control. These drugs reduce psychotic symptoms, such as those associated with schizophrenia, although they are not a cure, and the treatment for problems like schizophrenia will last a lifetime. The next ones are antidepressant drugs like Prozac. I'm sure all of you have heard of Prozac. Monoamine oxidase inhibitors, MOAs, lithium carbonate, the first one, lithium carbonate, and Depakote, effective against bipolar disorder also. So these treat depression, and they can treat bipolar disorder, and usually they affect serotonin and or norepinephrine uptake and destruction in this cleft, in the synaptic clefts. Anti-anxiety drugs are barbiturates and benzodiazepines. Barbiturates are sedation drugs. That's what a barbiturate does. It sedates you. So they work by sedating the user, and they are very addicting, these anti-anxiety drugs. And some antidepressants will actually work on anxiety disorders as well, but they should not be used to alleviate the ordinary anxieties of life. We all have anxiety. Everybody has anxiety. And I'm sure that a lot of you have anxieties about COVID right now, or there's something else in your life, cooking dinner for Thanksgiving for your family. That's anxiety provoking. It might be the most fun thing at all, but you got to make sure everything is exactly right. That's normal anxiety. That's typical anxiety. But when it gets in the way, it causes you personal distress and you cannot meet the demands of life, well, then you need a way to get rid of the anxiety. But it certainly isn't through sedating the user. And here's my problem with these anti-anxiety drugs that sedate. Have you ever been around somebody who's very anxious and they're always, like, you can tell they're anxious and it makes you anxious because of that? Have you ever been around an anxious person that made you anxious? Yes. I'm seeing a yes. Any others? Some more yeses. Okay. So you do know what I'm talking about then. But if I sedate them, then the outward appearance no longer is anxiety provoking. So we can be around them and we're fine. They don't create anxiety within us. But inside their brains, they are freaking out. They are anxious. Even though they've been sedated on the outside, the inside is still anxious. So if you know people who are anxious and you know they used to be anxious and they're taking drugs for it, ask them, are you still anxious inside? Because there are hundreds of these drugs and not all of them are just sedators. They do work. Some of them work on the inside as well to make that person not as anxious on the inside. And that's what counts. That's what we need. We don't need them to be, for our purposes, not anxious on the outside. We need them to be, we need to get rid of the anxiety in their brains. So try to find that drug that works that way instead of just sedating the user. Now, when these drugs are combined with alcohol and sleeping pills, it's probably the number one way that women try to commit suicide. Barbiturates with alcohol and sleeping pills put you to sleep basically and stops your heart and your breathing, and so you will die because of that. The stimulants are an interesting group. This particular type of stimulant, Ritalin, is used for ADHD. Well, ADHD is attention deficit hyperactivity disorder. If they're already hyperactive, why are we giving them a stimulant? Because the stimulant stimulates a very specific part of the brain, the central executive. And the central executive allows them to concentrate, to sit down and focus and be aware of what they're doing and not be distracted by every noise and every movement in their area. Even the sun coming through the window can distract an ADHD child. The problem here is that we are not really sure of when the central executive matures. It's supposed to mature around 5 to 6 years of age, but there's a spectrum of people, right? The maturity doesn't happen boom, boom, boom. It's a spectrum. Some people are slow, some people are fast. So the ones that are fast, they're great. They're good to go. They're golden. The ones that are normal, they go six years of age, first grade, they're ready. The ones that are slow, they're not ready. They're not ready to sit down in their seat, concentrate, and be and take orders and do what they're supposed to do, their tasks. So we give them Ritalin. But if their brain is still maturing, which now we have a group of people who are not yet mature, but there's a spectrum in that too. Some of them will never mature. Some of them are just maturing slowly. If the ones that are maturing slowly by 9 years of age, they should have a fully developed, mature central executive, but we don't take them off of Ritalin. We keep them on Ritalin for the rest of their life. And that's not right. That doesn't work well. So there's a controversy from concern that causes and boundaries of ADHD are vague and potential exists for overdiagnosis. When I was a child, my dad called me spastic. I was ADHD. There was no way to define ADHD. There was no such DSM, Diagnostics and Statistics Manual. So I was ADHD most likely as a child. But was I really ADHD, or was there something else? And I've already told you the story about me at my school, my first year in first grade school, and I had to repeat first grade for that purpose. But also, I have allergies or reactions, as some doctors like to call it, instead of an allergy, to certain foods. And my little cousin, absolutely. And I've already mentioned him and the fact that he's a perfectly controlled, well-behaved child unless you give him a maraschino cherry, and then he's a freaking mess all over the place, uncontrollable, because he has a reaction to the red dye in the maraschino cherry. Red dye, by the way, is created by crushing up insects. So if you are vegetarian, you can't eat anything that has red dye in it because it's insect related. But that was in the past. I don't know what red dye is anymore. But there are people who react badly. If he had been given a maraschino cherry every single day, or something with red dye in it every single day, he would have looked like he was ADHD, when in fact it was just a reaction to that particular chemical. And I had the same thing. I didn't find out until I was in college. And I had a reaction to a cup of coffee from one of the vending machines with caffeine in it. And I'm allergic to caffeine. I did not know it at the time, but my notes went from completely legible to totally illegible. And I started shaking and sweating, and I had voices in my head. And I skipped my next class and went right to the medical center at the university and said, there's something wrong with me. This is not right. And the doctor went through all the things that had happened to me that day. And of course, the vending machine, he said, have you ever had coffee from the vending machine before? No, I was just late and I didn't have time to grab my normal orange juice. And so I got the vending machine coffee because it was right there in front of the classroom. He says, okay, so he removed everything from what I was eating. I had to eat boiled chicken and rice for 2 weeks. Nothing but boiled chicken and rice for breakfast, lunch, and dinner, and only water. That was it. And then they started adding stuff back. And it turned out I was allergic to citric acid. The orange juice I had every single morning, 3 glasses of orange juice. Plus, I was allergic to processed cheeses. My lunch is a pizza. That's the tomatoes is citric acid, and the cheese, processed cheeses, plus new made dough, freshly made dough. There was something in freshly made dough that affected me. And peanut butter and jelly. Jelly is citric acid also. So I was just killing myself with the foods I was eating. Now I know that today, and I don't eat these things very often. When I do, I can feel the change happen. Now I use this to my advantage. I know what orange juice does to me. And if I wake up and I've got like a little cold or something, I'm feeling down or depressed, my wife has orange juice. She drinks it. So I have a glass of orange juice and boom, I'm right up on top of the world again. You couldn't tell that I was feeling bad. So I use it to my advantage, knowing what it does to me. But you have to know this, and children, they don't know what's going on. And the parents, if they're clueless, they're causing their children all this pain and suffering and then giving them Ritalin to keep them control. And that's just not right. It can also slow the growth rate of children as well. So many so-called ADHD kids may just be allergic to specific foods and may actually be misdiagnosed as ADHD because stimulants are so easy to prescribe. The real causes just may be ignored. And I'm going to stop right there because it's almost the end of the class. And we'll pick this back up and finish it the next time we come back, which is after Thanksgiving. So you all have a very good Thanksgiving. Call your moms. If you're not having Thanksgiving with your moms, call your mother. Bye. Stay safe. Stay healthy. Yes, Ava, you have a question about the essay. Tell me about your question. Where should I submit it when I am finished? Oh, is that it? Oh, that's easy. Okay, hold on 1 second. Let me show you. So here we are in the class, right? You see the class? And over here you say you will have one essay. If you click on that one essay, click there, and then scroll down, and here it is. That's where you submit it. Are you cool? You're very welcome. Have a great Thanksgiving. Bye. All right. And that's all of them. Very good. And we're done.